we have Dr. Eric London, a trailblazer, a pioneer of supporting research for autism, and he's worked on so many areas, from neonatal stages to clinical trials to brain tissue. Yeah, so he's gonna tell us all about it, and also Eric is a proud father as well. So.
Okay. So my talk is going to be very practical, maybe even almost wanky. I'm very interested in the concept of getting good ideas actually out into the world. So many times, I think people have great ideas. Maybe the rest of this conference we're going to hear great ideas. But the question is, will this be distributed out into the world, and will people be able to benefit from it? So my odyssey started in the autistic world. That's my son Zach, who's on my shoulders, and this is he was diagnosed in 1989. At that time, I was a general psychiatrist, mostly doing work with addictions, and in the state of New Jersey, where I was, there were very few people who were doing anything at all in the field, and I started to just read about autism, and within a few months I started getting referrals because people just knew I was interested in it. So over the years, since about 1989, my clinical practice has increased in autism to being close to 100% autism and developmental disorders. I've probably seen about 1,000 people over the years, and of all kinds of varieties. And in about 2008, 2006, I started my career, my research career, and I'm at the Institute for Basic Research in Staten Island. In 1994, my wife and I, kind of horrified by the fact that not only was there no one around to treat autism, but there was very little research going on in autism. So we started what was probably the first, I'll call it serious, organization to raise money for autism research. And if you want to know all the details, we got a very nice write-up in the book In a Different Key. And it's a very good book, even if you don't care about my story. Okay, so this is too small. I have to. Okay, so this is about NAAR, and the context is in 1995, the NIH did their first what they called State of the Science meeting. So it was the first time all the people at the NIH who were interested came together. They brought pretty much all the people who had published on autism together for this meeting. The highlight of the meeting was Francis Collins, who was the head of the Human Genome Project at that time. He went on to be the head of the NIH. He made this announcement that if we could just get 200 SIB pairs, we would crack autism genetics. Now we probably have 200,000 SIB pairs and trios and all sorts of things, and we really still haven't done it. So we got involved in putting together genetics groups. There was no tissue available, no human tissue available. Tissue is very important to being able to see really what's there. In those days, MRI wasn't quite as well developed as now, but even now, there are things you can only measure in real tissue. So we started the Autism Tissue Program, which now has turned into BrainNet, and so it's still running. Simon's Foundation is funding that. We realized that people were getting diagnosed, but by the time they were being diagnosed, we had no idea what was going on earlier than that. So if they're being diagnosed at age 2, 3, 4, 5, we didn't know anything about that. And there were a couple of investigators who were looking at the infant siblings, we brought them together, we got the NICHD involved, and we started the Baby SIBS initiative. That's still going. There's a Baby SIBS consortium, and over the years they've put out lots of really good, valuable research using that method. Epidemiology. When I first got involved, the number was 4 per 10,000 for autism. All the parents were coming to us saying, this is crazy, everyone on my block has autism. This must be wrong. And so we went down to the CDC, and I sat down with a few people, and for the first time probably in history, I sat with a government official, made my case, and they said, you're right, and we're going to start doing that. So that was how the ATOM program got us started. And now we get numbers every 2 years from the CDC, and the latest number is 1 in 36, or 270 per 10,000. Why the numbers have shifted is too much for my talk, so another day. We funded young scientists. We wanted to attract young people into the field. In those days, I spoke to some young people doing fellowships, and I said, aren't you interested in autism? And their answer very quickly was, there's no money, I can't get a grant, so I won't be able to do it. We also actively attracted people doing research that we thought the research was pertinent to autism. And so we brought a lot of really smart people into the field, and some of those people we brought in are now leaders in the field. We had a language initiative. One question we were posing back in those days was, why is language such a big issue for us as opposed to almost any other brain disorder? And then probably the most important thing we did was we gave away $35 million to over 200 projects. So now I'm going to put up the treatments for if you have an autistic individual. This comes from the NICHD's website, and as you can see, there's lots of different treatments, and if you link onto any of them, they'll subdivide them and tell you more about it. This comes from the Autism Science Foundation's website, and these are biomedical, non-evidence-based treatments. And you could see some of them you may be familiar with, some not. Some of them are probably just plain old crazy, like bleach therapy. Some of them may be very good. Problem is we don't know. We really don't know what's going to work, what's not going to work, what's going to work for some people, what's not going to work for other people. Some of them are dangerous. Chelation has killed based on a mercury hypothesis, which probably has no scientific basis. There's more therapies. Some of these may work, some may not work. We really don't know. Holding was a therapy that people were doing in the old days where you squeeze the kid and talk to him. And there was actually a death from that. Then there are the auditory therapies. I put up 6. I don't know how many there really are. By the way, this list, this is like not complete list. I just found a few. And so some of these might be very good, but this is kind of what happens if we don't pay attention. So in 2003, the American Speech and Language Hearing Association weighed in and said there's no evidence, AIT, that's the second one, the Berard therapy. There's no evidence that it works, and they think it's a violation of the Code of Ethics if you choose to use it. So not only don't we know, but the standard caregivers, the clinicians, try very hard to push us towards things that are going to work and are not going to kill us. And so, but they really don't know where to draw the line. And we've not provided the evidence for them to do this. So how's one to know? So there are so many treatments. Again, these are partial lists, but very few real answers. The truth of the matter is clinicians probably get trained in 1 or 2 methods and then they apply it to everybody. If you look at the bottom bullet, there was a Cochrane review for ASD. They reviewed 17 different treatments. So the Cochrane, for those who don't know, is meta-analysis. They bring together all the literature, they look at how well the studies are done, and they decided that for the first group, there was weak evidence. Now, I put aripiprazole and risperidone up in big letters because these are FDA approved, yet the evidence is still considered weak that they work. And then at the bottom, there are ones that there's no evidence that they work at all. So if you were to take this seriously and you're a clinician and you walk into my office, I would just say, well, we really don't have anything to treat you with. Why don't you go home, come back in 50 years. So this is the state of young parents when you're getting the diagnosis. You want to do something. It's really hard to know what to do. And I could tell you as a parent, it was pretty wrenching. And things are better now than when I was there. And the doctors are not in much different state, what to do. In a survey, more than half of the primary care doctors expressed a need for more knowledge and training, and a similar number listed limited awareness and access to community resources. So they really don't know that much about autism. They don't even know really who to refer to in many places. And so it makes them not want to treat this community. So now it's not, I don't want to get too hopeless, so I'm going to try to provide some answers. So I think there are 4 main points that I would like to make about things that can be done. They're certainly within the realm of possibility, but it will be like turning around a battleship in some senses of the word. So number 1 is the diagnosis is invalid. The diagnosis stinks. And if we get tied into the diagnosis, we're going to hold up progress. I've written 2 papers on this. I hope someone's reading them. The second one is that the methodologies that we're using to study the treatments are incorrect. Most funding agencies only entertain double-blind placebo-controlled trials. We're not ready for them. We don't understand the inclusion, the exclusion. We don't understand the endpoints. We don't quite know who we're treating because the diagnosis is so broad. Now, I put in there that tech and STEM can give us a big leg up on the idea of doing observational research, and I'm going to come back to this concept. Number 3, treatments do not exist in a research vacuum. There are a lot of treatments, especially in educational or behavioral treatments, that if you read them, they're really, really elegant. But if you ask special ed teachers, why aren't you doing it? They just look at you like you're out of your mind. It works in a lab. It doesn't really work in a classroom. It doesn't really apply. But the problem is that if you're a stakeholder of various kinds, a teacher, an insurance company even, what do you want to get behind? Whoops, actually, the 4th one. Oh, the 4th one's the most important. There continues to be little or close to 0 funding for treatment research. The NIMH just basically doesn't do it, and they're pretty open about not doing it. The DoD does do it, but they have very limited amounts of grants. The Simons Foundation is very interested in genetics, so they do very little treatment research. So if you're really interested in getting treatment done, where to go? Okay, we'll start with diagnosis. So we still use what's called the wise professor model. I love that idea. So back in the olden days, you would have someone like that's Bloiler on the left, and it was 1908, and he coined the word autism. It was really a symptom of schizophrenia in his mind. In the middle is Hans Asperger and then Leo Kanner, who really described autism as what we know it today for the first time. But what these were just observations. They described their patients almost in essay form. And they were such good descriptions that we've just adopted it, and here we are like 100 years later, kind of still stuck with their observations. So we'll just skip to the bottom. Sir Michael Rutter, who was on our advisory board back in the old days, was one of the pioneers of autism. He created the ADOS, for those of you who use the ADOS. And I found this quote by him, which I think is really nice. People ask, what's really the definition of autism? What is autism? And his answer is, there's no point in starting with the word autism and defining it. It's just a word. It's just like any other word. It means whatever you want it to mean. So we have the ability to define the people we're seeing and what their issues are. We don't have to stay stuck with a 100-year-old definition. Even Kanner wasn't happy with the word autism. In 1965, and this is also a beautiful quote, he recognized diagnostic heterogeneity and opined that children hadn't read the manuals and don't fall into clear categories. Kanner emphasized no matter how well developed our criterion is, each child is a unique person. And that leads to personalized medicine, right? We really have to treat the person, not the broad diagnosis. So I said ASD is not a valid diagnosis, and I guess I got to prove it a little bit. Here are 4 types of validity. The top one is face validity, and actually autism does do pretty well with face validity. That's partly because it's circular, like we describe it, and then we create an ADOS to prove what we describe. But that's about it. It's not the descriptive validity is terrible because there are all these comorbidities and it blends into all other disorders. The predictive validity is terrible. You can hardly predict anything with a diagnosis. And the external or construct validity is bad. It's just not panning out for almost anything. So it's really not a good diagnosis. I'm going to skip over this slide because it's pretty much the same thing, except to say that in the bottom, the complexity of the diagnosis that we're stuck with means you need to be an expert to diagnose it, which pretty much writes off all the primary care doctors and even in general psychiatrists and neurologists, you know, because if you're not an expert, you can't do it, which means you have to wait to see these experts. And while you're waiting to see these experts, the kid is growing up and it's going to be too late to do a lot of things. So I could have summarized everything and just shown this slide. Is this one disease? This slide I've been using for probably 25 years now. I haven't gotten past it. So who are we studying? Are we going to include people with epilepsy or do we exclude people with epilepsy? Do we include people with attention deficit or do we include them? So you can bite off the whole, you can take little chunks, but it's very, very hard to separate this out into any meaningful way. So our inclusion criterions are, if you go through the literature, they're pretty daffy. Okay, do I have a solution? I think so. So I would change all of developmental disorders to just calling them developmental disorder. And then with features of X. So then the diagnosis becomes simple, even your average family physician could do it. And with features of X means it really becomes an assessment. So you're not just looking, say, oh, you're autistic, do you have this, do you have that, do you have that? Okay, now go home. What you do is you look at the disorder and then you ask all the questions about really what's going on with that person. And then if you're going to do treatment, you're going to be treating the features of X. Okay, 2, methodology. So I'm going to take a lot of this from Don Klein, who passed away in 2019. He was one of the great pioneers of psychopharmacology, and he was a proponent of the benefits of observational research. So, you know, and again, I think this is a beautiful story. This is his own way of telling it. In 1953, at Creedmoor State Hospital, which is here in Queens, which was a 6,000-bed state hospital, with few therapeutic aspirations. Now, for those of you who don't know the history of psychiatry, in those days there were 2 kinds of psychiatrists. There were psychoanalysts, and there were people that were called alienists. And the alienists went into the state hospital, and they basically warehoused people. So, but psychiatrists would have to rotate through these, as they were being trained, they would have to rotate through. But then there was a seismic shift in psychiatry between 1950 and 1970. And the pace of discovery of an entirely new class of psychotropic drugs was dizzying. And look at the list: lithium, LSD, chlorpromazine. Virtually all the medicines that we're still using were discovered during this time, or their updates. In other words, say chlorpromazine is antipsychotic, so now we have Risperdal. But for the most part, almost everything we're using now was discovered between 1950 and 1970. So what was the secret? The secret was observation. You would sit in Creedmoor and you would observe these people. And sometimes you would try treatments. And sometimes the treatments were incidental. The one famous one being lithium. Lithium was being used in a trial for kidney disease. So they gave it to a couple of people who were psychotic for their kidney disease, and lo and behold, in a couple of days, their psychosis went away. And that's how we discovered lithium. Can't do that anymore. No one's watching. And the reason why no one's watching is because we've changed the funding mechanisms. In those days, the Veterans Administration and even the NIMH were supporting studies on marketed medications. No more. The NIMH is very clear about the fact that that's the job of private industry. Now, of course, private industry generally doesn't have any interest in studying marketed medicines, so it just doesn't happen anymore. So serendipity was replaced by rational drug design fostered by translational research. And of course, this could come right out of the NIMH's website. So it's a great idea. If we just know the basic science, then we're going to be able to do something rational and we're going to cure it. The only problem is in 50 years, close to zero has come out of this. So it's a great idea that just hasn't panned out. And being scientists, usually you should look at the data occasionally and see whether you're going in the right direction. So Klein said, can serendipity be revitalized? And he said himself, probably a utopian fantasy. But he said, just imagine we had a network of computerized science, but this is in 2008, run day hospitals devoted to pilot trials of safe but unusual medications. But the good news is we can do this in autism because we have places that are called schools. And in schools, the kids go every single day and they're there for 5 hours and they're being trained. If only we could get the educational people and the medical people to cooperate. Number 3, integration to existing systems. So autism cannot be diagnosed reliably until 24, maybe 18 months if you're very good. Currently, the mean age of diagnosis in America is 4 years and 3 months, but it ranges up to, 5 or 6 years. Now, why is this a big deal? Well, if you look at this graph, your brains develop 25% at birth, 75% at 2 years, and 90% by 5 years. So by the time about half the people are diagnosed, their brains are fully formed. Now, bullet number 2, how much of what we call autism is determined by an early biologic insult and how much is due to aberrant development? And the answer is we just don't know. We don't know because we can't identify the very young kids and know what it would have been like. If we can optimally intervene at a very early age, it's very likely we could devise treatments that would normalize development. Okay, so we're screening kids in the PCP's office, in the family doctor's office. So this slide, basically, I'm showing that, number one, only in certain studies, 28 to 60% of them are actually doing any screening at all. And even if you are screening, they're using the MCHAT, which is very quick and has some good points, but if you look at its positive predictive value, we're talking in the neighborhood of 17%. So it's not a very good way to really do screening at all. Screening is only meaningful if it leads to intervention. If in a study of 14,000 children with developmental disability or delay, it was found that only 18% of those who were eligible for early intervention received a referral. And out of that, only about a quarter of them actually got enrolled in early intervention, leaving a grand total of 5% of the kids who needed early intervention got it. And this was a big study done out in Washington State. PCPs are just unable to do the job adequately for various reasons. It's probably not their fault. Most often they're overwhelmed. You get 8 to 12 minutes per patient, and they have to see acutely ill people also. So screening is just not the priority. The solution? Well, let's create an entity whose task it is to do screening. This can be done by easily trained people outside the PCP's office, and much can be done using neurophysiologic lab tests, which I'll mention in a minute. And this entity could be under departments of health and would be responsible for the screening and the referral to early intervention, taking this burden away from the PCPs. So this is the idea. You can, for example, we could do this with EEG. The EEG could be done in a few minutes. It could be sent to a central processing area, and then the results can be forwarded right back to the pediatricians. This is eminently doable, and we did it. Well, I didn't do it. Someone I collaborated did it. So this was done on infant siblings, a high-risk group, and using a measure of entropy, or chaos versus synchrony, we were able to separate out, these are all the autisms, these are the high-risk kids who did not become autistic, and these were the low-risk kids who didn't have autism in the family. So we were able in the baby siblings group to separate it out very nicely. What we really need to do is do this in a typical birth population to see if it works for everybody. And Liz talked about this, I'll just talk about it again briefly. This was recently published using auditory brainstem evoked potential. You could see that every peak, the red lines separated out nicely. So if this pans out, again, in typical populations, we'll be able to make predictions very, very early, as early as birth, maybe. And Liz also talked about this, intentional versus random motion, and we're very interested, that motion seems to be probably the earliest predictor that people have noted up until now. And so by analyzing the motion of very young children, we'll see where they separate from. Okay, so I'm on to my last few slides. I see time's running out. Okay, so what we need is we need an entity to promote this kind of research. Right now, no one's funding it. So I have two exemplars up here. Number one is MAPS, the Multidisciplinary Association for Psychedelic Studies. And this was created in 1986 by Rick Doblin. So his goal was to get psychedelics to be legalized, FDA-approved drugs. It took him since 1986. He's raised over $130 million for this task. And if you look at this bottom slide, you could see that their data is outstanding for post-traumatic stress disorder. And this was a phase 3 study from the FDA. And there's another study going on which is equally good. And it looks like it's going to get approved. So they funded all the research. Without MAPS, none of this was going to happen. Okay, the second one is the Healy Center for ALS at Mass General. So the ALS is a terrible disease. People die. Sometimes they die pretty quickly. So what they want to do is committed to radical change and accelerating converting ALS to enduring treatments. At its core, it's a variable disease just like us, and so they know that one treatment is not going to fit all. And the key to their success is collaboration. They have 70 active sites doing basic science or clinical work. They do something called a platform trial method, where you could see there's a standard of care, 2 interventions at the same time. People get put in. If something doesn't work, they drop the drug and they add another drug. And so things go very quickly, it's much less expensive, and the people want the trials. So there's a revolution in neuroscience and technology. The question is, in autism, can we get on board? Now there's nanodrugs, psychedelics, brain stimulations of all kinds. This is transcranial direct current stimulation, which we're doing. And I'll just show you this one slide. Oh, did I? Disappeared. Oh, okay, good. This one slide. So this is a kid, a 10-year-old, who couldn't do verbal imitation. We did the transcranial direct current stimulation for 2 weeks, and he started to echo. He started to be able to say ah, he could do ah. And then we went away, but his behavioral program continued, and look at what happened to his verbal imitation. Just 2 weeks of this little stimulation was so powerful. So this is my email. If anyone is interested in putting together another organization like NAAR, please contact me. I'll be, I work for free, so it's very easy. I'm salaried. But I think it's absolutely necessary that we have an organization that could push through some of these ideas. And this is Zach and myself now. Thank you.
Thank you, Eric. And that's the beauty of being salaried, that we work for free, 24/7, no compromises. So, and I look forward to continuing collaborative work on all these different areas that we can advance, and hopefully an organization will fund it.